I'm going to make a very, very small bend at the end with this master apical file, and then I'm going to manually place this master apical file into the distal canal. What I do notice is the stopper on the glide path file, if I measure at 15 millimeters, is just too loose. So I am going to use a different stopper on my glide path file. In this case, I'm using the defined stopper, and this grips the file really, really nicely. So again, significant resistance when I'm shaping this canal. This is essentially what every root canal I would like to look like. And this is why doing a root canal is satisfying and also quite addictive. So hello, welcome to this week's Friday clinical case, and this is an exciting case to show you today because these are the types of post-op radiographs, as we can see here, that just make your day. These are the types of root canals that once you take an x-ray right at the end is exactly what you want to see. You want to see a nicely shaped, tapered obturation, maybe a little bit of sealer puff at the end with a bit of bioceramic. So this is kind of like the god tier of root canals, in my opinion, and this is what I strive to do every single root canal I do, and I don't often achieve this type of root canal, but this case has also got loads and loads of learning points, so I'm really excited to present this for you today. But before we start, what I would say is that when we look at the metrics of the channel, only 50% of the people who watch these videos regularly are subscribers. So if you could do me one favor, if you do anything for me today, it's free, it's easy, it's simple, just hit that subscribe button. And if you want to bring the support for the channel even further, we've got a membership program, we've got early access to content. We usually have about 3 weeks videos in advance on the membership area in YouTube, and also we have exclusive access to content. We've got a fantastic Endo access video, which is only available to members. We'll also have a video newly uploaded for the newly qualified dentist, and how to sort of survive in your first couple of weeks as a newly qualified dentist. So we'll get on with the case. So this is a lower right 6, and this was referred to me by a very, very experienced colleague of mine who works at the same practice with me in North Wales, and he had crowned this tooth with, I think it's an Emax or a lithium disilicate crown. It's down as the zirconia, but when I was accessing the tooth, I didn't notice the kind of sparks that fly off when you're drilling into it as zirconia crown. But nevertheless, the reason why this was referred to me mainly because accessing this tooth was particularly difficult, and you've got to really, really be careful you don't perforate this tooth, because obviously accessing through a crown can be difficult with your orientation with your burrs. But also we can see here on the radiograph there's no real obvious pulp chamber. So that was the reason why this patient was referred to me today. So if we move over to the video here, the first thing I'm going to do is I'm going to access this crown, and what I do is something that I wouldn't suggest to the normal dentist, is I actually put a rubber dam on this tooth before I access. The problem with doing it with a rubber dam on is sometimes it can be difficult to orientate your burrs, but I felt in this case I am happy to access the tooth with a rubber dam just because of my experience. And in the first instance, I like to use a pear-shaped burr to access, okay? But once I have access through the crown, okay, I'm going to move up to a larger burr, and in the first instance, I'm going to do a very, very, very conservative access. So it's a very, very small hole. And what I'm looking for here is any one of the mesobuccal, misolingual, or the distal canal orifices, and then I'm going to open the access and refine from there. So I have a little look here. I'm being very, very ginger because I don't want to perforate the tooth, and I'm just ever so slightly accessing this tooth, and I feel like actually I need to go deeper. And once I do get deeper, I notice something straight away, knowing that I'm my orientation is definitely off in this case, because when I look deep into the access cavity, I can see that there's a definitive colour difference, and I know that I am on absolute margins of the walls of the tooth and the pulp chamber floor, because the pulp chamber floor is always darker than the walls. So in a way, the fact that I've accessed in a bit too mesial in this tooth, well, I know it's not sort of conforming to the conservative access principles, but also I know that at this junction is where I'm going to find my canal orifices. So that's a really, really important thing to be aware of there. The junctions of the walls and the floor, the colour difference is always a little bit different. So given this fact, I'm going to do a bit more refinement with my fast handpiece, and then because I'm worried about perforation, I'm going to use these diamond-tipped ultrasonic tips here to access in a very, very sort of controlled manner. And I feel like maybe that I found an MB1 using the root fusion lines, and I have accessed some kind of canal orifice here, but it's not negotiating quite nicely, and I have a very, very kind of sort of nominal look for the misolingual canal, but no luck. So I'm going to do more refinements. I'm going to be looking for this distal canal and having a little fiddle around here, and now I can see the distal, but it is still quite calcified, and I'm going to poke around here with the file, and you can see here as well that I've probably accessed this tooth too mesially. And can you see how easy it is for me to perforate this tooth if my orientation is off and I haven't used this kind of careful approach? So we found the mesibuccal, we found the distal. I'm going to have a little look around now for the misolingual with my diamond-tipped ultrasonics. And as you know, these ultrasonics are on a special unit and they have a lower energy. And after I've negotiated around with the ultrasonics, I can see that I've now opened up a mesolingual orifice. And I'm going to try and access down this mesolingual orifice, but I'm getting severe resistance. So what I do is I measure to the furthest point I've reached in this mesolingual canal, and it is 16.5 millimeters. And I'm going to do this kind of step back approach, okay, where I'm going to use a glide path file, a 1503 at 300 RPM and a very, very low torque setting, up to 16 millimeters. So I'm opening up the coronal to mid third in this canal to sort of release the grip around the file, so hopefully the hand file negotiates a bit further. But once I've opened up the mesolingual, I want to have a little look down the mesibuccal, and I'm using a D-finder in this case, just have a little look around and see if this negotiates any further. But I'm getting severe resistance. So I'm going to use a smaller diameter file. So I'm using a size 8 instead of a size 10. And also I'm going to use a smaller length file. And this gives me a bit more stiffness to see if I can negotiate down this tough canal. But I'm still not having any luck at all. So I'm going to just, again, I like to have a fresh mind, not get too frustrated when I get down canals, is I'm going to move over to mesolingual. I know that I'm negotiating further with this, so I'm going to place my size 10 D-finder in this canal, and I'm going to have another little fiddle around and see if I can sort of negotiate any further. And the difficult thing with this is when the patient's got a very, very small opening, and the access is difficult, then trying to reach it into the hole can be tough. So I'm just hooking up the D-finder to my apex locator. I am not reaching 0 at all, so I'm just going to move the stopper to as far as I can get, and I can see that we have reached a little bit further at 19 millimeters. So I know that we are further negotiating, so we're going to do that step back approach again. We're going to use a glide path file at 18. Again, remember, it's the same thing over and over again. We're going to release the canal grip on the file further up. You don't want to be pushing this any further. And then I'm going to get actually a higher diameter file at 17 millimeters, so this is 2 millimeters away from furthest point I've reached, just to really, really open up this canal space. And I'm not worried about conservative access at this point, because I know that this is my masterclass master apical file. I'm going to be shaping this file regardless at 17 anyway. So after I place my size 10 D-finder into the misolingual, I'm going to have a little tiny watch wind, and then when we hook up the apex locator, we can see now that the working length is 20 millimeters. Just notice how I have done this in a very, very stepwise approach, and I've not rushed down to the apex too quickly because I would have essentially ledged or blocked the canal. So I'm going to do our now final shaping with our glide path file up to 20, and I'm going to use our 25 variable high flex at 19.5 millimeters. And this is now the mesolingual has been shaped successfully. We're then going to try down the mesobuccal again, but no luck. So again, I just want to park that to one side and try and get down to the distal. Again, we're getting severe resistance, and in this case we have reached 17.5 millimeters, so we're pretty close, you know. And I'm gonna again do that sort of step back approach where I use a higher diameter file at 16.5 millimeters, so this is 1.5 millimeters away from the furthest point reached. And now you can see that the distal is quite a bit more open than it was. This is going to release the grip, remember. And I'm going to use again a smaller diameter file with a smaller length. This is going to give me a bit more control. We hook it up to the apex locator, and we're still not quite getting to length. So I'm going to do something that I never do. I'm going to make a large bend in this D-finder rather than a very, very small bend at the end. And this, for some reason, just passes the obstruction or the ledge. And when we hook it up to the apex locator, we can see that we are over. So I'm going to bring this back. And then once we reach 0, this is our working length. So we just kind of adjust the stopper, which can be a bit difficult sometimes when you know the file's right up to the hilt. And then when we check the working length in the distal, this is 19 millimeters. So we're really motoring along here. What I want to do now is I want to do some final shaping, and I'm going to use this 51504. And what I'll notice here is that I'm struggling a little bit, and then the glide path file kind of drops past some kind of, it must be some sort of ledge or obstruction, and that kind of a heart dropping moment. So I'm going to be really, really, really mindful that there's definitely a ledge there, and even the glide path file was struggling to get past. So I'm going to use my final shaping file. This is a 25 variable at 18.5 millimeters. But in this case, I'm concerned about the bend in this distal aspect, and I'm worried about ledging. So I'm going to make a very, very small bend at the end with this master apical file. And then I'm going to manually place this master apical file into the distal canal. And what this does is it kind of it manually places the file past the ledge. And once you've passed the ledge and you're kind of near to the working length, I'm going to use T mode, which is this mode that goes a reciprocation movement. In this case, I like to do 90, 90, 90. And once I feel that I have pushed this file through or past the obstruction or the ledge, I'm going to press the button again, and then it turns into a rotary action. And this kind of shapes out any kind of ledge or any difficulty. And you know, lots of irrigation, and we can see now that we've got the mesolingual has been shaped and the distal has also been shaped. So now we're going to have to move over to the troublesome MB canal. And don't forget that, you know, this has been soaking in bleach for a very, very long time now. So any kind of organic tissue that's been blocking this canal would have had time to work its magic. And the worst thing about the MB is it's the canal that the patient has to open super, super wide for. So if you have had a very long appointment, the patient now has to open wide, it can be a bit difficult. And I'm not really getting down the MB very much, so I'm going to do a bit of very, very nominal coronal shaping, and then I am going to move over to my D-finder, and I feel like I'm negotiating a bit further, but I am still getting that kind of resistance there. And the worst thing for me to do now is to just really push this nice and hard and really trying to ram this file down further. I am putting a little bit of pressure on this tooth, but nothing too major, because obviously what you might do is you might fracture the file, you know. So I'm going to adjust the stopper again, same as the old all the other 3 canals. We can see here that the furthest point we've reached is 15.5 millimeters. And then what I do notice is the stopper on the glide path file, if I measure at 15 millimeters, is just too loose. So I am going to use a different stopper on my glide path file. In this case, I'm using the defined stopper, and this grips the file really nicely. So you know, I know exactly how far I'm going to be going down with this glide path file. And I have the similar problem with a size 25. When the stopper goes to about 15 or 14, it's too loose. So I'm just going to use a different stopper on this master apical file. So at 14 millimeters, so I know that I'm not pushing this too far. And the thing with the step back approach is you don't want to be shaping too far down, because you're going to ledge the tooth. Okay, so that's why we need to make sure that the stopper is in the correct position. So once we've shaped the coronal to mid-third and the mesiobuccal, we are going to place our hand file down again. We're going to hook this up to the apex locator, and you know, we are negotiating a little bit further, but you know, a lot of fiddling around, a lot of messing around. I still notice that we're not quite getting to length, but we're getting closer. We're going to adjust the stopper, and we have essentially moved 3 millimeters, which is great. I am now slightly worried about the glide path file that I've been using for the 3 canals, and I'm concerned that this has been put under a lot of pressure. So what I do is I ask the nurse for a new glide path file. I am getting severe resistance as mesiobuccal, and I've fractured too many files to sort of take this chance. So we've got a fresh glide path file, and then I'm going to do another negotiation attempt here with my D-finder, and I'm going to hook this up. I notice that it's going to the correct length. It's going a bit further, and we'll hook it up again. We're still not getting quite 0 though on the working length, and now we've only reached 0.5 millimeters after all that shaping. So I'm going to prepare a size 8 D-finder. I'm going to prepare it up to 19.5 millimeters. The stopper, sorry, we're going to snip off the stopper end, and then I'm going to just bend the end of this D-finder to where I've snipped this stopper, so I know where this kind of bend is. And hopefully this hand file is going to negotiate to 0. So we're going to place the prepared size 8 D-finder in the mesiobuccal, and we're just going to have a very gentle watch winding in the area. And what I do notice is now this is reaching quite far down. We hook up the apex locator, we have a little fiddle around, and we notice now that we've got 0. And when I pull this hand file out, I notice there is a significant amount of resistance. So I'm going to be very careful when I start to do the final shape in this file. And the working length has been found to be 19.5 millimeters. So we weren't that far away. And what I've noticed, and the way you look with a lot of my videos, is sometimes when you're not reaching the end, you're probably very close. So just a lot of patience. And then we're just going to start the shaping process. I do the glide path file, and now I'm on to the master apical file. But I noticed there's again significant resistance when I'm shaping this canal, and what I don't want to do is I don't want to push this master apical down any further than required, because you're going to ledge the tooth. So all you need to do is just take the file out, recapitulate, irrigate, and then just very slowly negotiate to length. And we can see now in the access cavity that we have we've shaped everything all lovely and nicely, and it's looking fantastic and symmetrical down there. I'm gonna do the cone fit radiograph, and what I don't notice actually is that when I measure this cone fit and I place it in the distal, is that it actually doesn't fit to the correct working length, this cone. And this is significant when we take the cone fit radiograph, but at this point I haven't noticed. So what I do is I place the cone in the distal. I then place the cones in the mesolingual and the mesobuccal. And when we take the cone fit radiograph, we can see that the distal is too far away. This is too far away to be within the acceptable range of the radiographic apex. So what I don't do is I don't obturate straight away. I do clean my tray table ready for the obturation though. And what I do in this instance is I just pull all of the GP cones out once the cone fit radiograph has been taken, and then I place these in our disinfecting ring. That's really important. Remember, the GP isn't sterile, so you want to make sure that the GP, if you haven't, you cleaned all the canals, you don't want to be putting dirty GP into the canal space once it's all been cleaned, because remember, bacteria is what causes root canal failure. And I'm having a little look at the distal cone here, and I think the reason why I think maybe it's gone to length is because it's been a bit bent. So the first thing we do is we want to check the working length, and that's been confirmed as the correct working length that I had before, and I'm just going to reshape the distal with my rotary files, and I'm being very, very mindful not to shape this too much. Remember, this rotary file has done a lot of shaping, and the amount of files I would say that I have fractured at this point is probably most than any other sort of stage of root canal. I've always fractured a file when I'm just doing a little bit of shaping, so just be mindful of that. And then I'm going to get a new GP cone. I'm going to make sure I've measured it correctly, and I'm going to make sure now that I'm definitely pushing this to the correct working length. You can see where I've crimped this GP cone, that it now fits to our reference point, and then we take the new cone fit radiograph, the second cone fit radiograph, we can see that the distal cone is at the correct length. So we're now happy to do some final obturation. And then before we do our final obturation, of course, we've got our final irrigation protocol. In my case, I'm just going to remove the GP cone, put that in a disinfector, and then I am going to do a first rinse with sodium hypochlorite activated. Once I've done that, I'm going to do a second rinse with 17% EDTA activated, and then a final rinse with sodium hypochlorite activated. And of course, we need to do some drying as well. So we're going to do some obturation now. I'm going to start with the distal. I'm going to prepare the cone. I'm going to dip it into isopropyl alcohol. I'm going to dry it off, get rid of the residue of the sodium hypochlorite. I'm going to crimp the cone, and I'm going to place it to one side. I'm then going to use a hand file, a disinfected hand file. I'm going to give that a little bit of a dry off. This is going to introduce the bioceramic to the full working length in the canal space, and then I'm going to directly inject bioceramic into the distal canal. Remember, I'm doing this under high magnification. Not advised to do if you're not using high magnification. And then I'm going to place our hand file to about maybe 2 to 1 millimeters away from the working length, just to introduce the bioceramic to the rest of the canal and stop this vapor lock. And then I'm going to very, very, very gently and carefully place the GP cone to length, making sure that the little crimp mark, this is the point to where the working length is, marries up with our reference point. You can see here that it marries up very, very nicely. And then once we've done that, we're just going to use our heated plugger to remove the excess. Of course, you could do this right at the end with all your 3 canals with loads of excess out. But what I notice, if you do this with a heated plugger, cuts off a little bit of the GP, and then it might catch another GP, and as you pull out, you pull everything out. So I just like to prepare each canal individually rather than doing the same stage in all 3 canals. Okay, it just gives you a bit more control. We're then going to go for our MB obturation, and it's all really essentially the same protocol as the distal. We're going to obviously dip it into isopropyl alcohol, prepare everything ready. So when you inject the bioceramic into the canal space, you then don't want to be fiddling around with the GP cone, giving it this, giving it that, because although it takes a few hours for this bioceramic to set, I would say that it sets a tiny little bit after the first maybe 5 minutes. So you really want to be obturating this tooth when the sealant as it is at its most liquidy, if that makes any sense at all. Mainly because you want it to flow into all the nice areas here. And then when we inspect the final post-op, I mean, this is just, I'd take a picture of this and have it hung above my my fireplace at home. This is absolutely gorgeous. This is essentially what every root canal I would like to look like, and this is why doing a root canal is satisfying and also quite addictive, because you're always after this kind of approach. You've got a really nice prep. It's relatively conservative, although what I would say, if you look at the post-op here, and what I'll do is I just annotate on the tooth, you can see the point immediately where I went a little bit too far and I sort of cut into the wall. We were talking about before about the difference in colour, but it's all just about recognising those signs and then just treating accordingly. But overall, it's a perfect result. I took this x-ray and I looked at it and I just, chef's kiss. So, if you haven't subscribed already, please subscribe to the channel. If you have any questions, if you have any criticisms, please comment in the section below. If you feel like you would have done something completely different in this case, please comment, and I will see you in the next video next week. Bye-bye.